urinary system disorders. Starting with diagnostic tests for urinary related problems. One of the most common tests that's done in the lab is called a urinalysis, and these are some of the things that you would be looking for abnormal constituents, and these would be present in significant amounts to show up in a test. Blood hematuria, small amounts can relate to infection, inflammation, tumors. Large amounts, which would be called gross hematuria, could be increased glomerular permeability, or it could indicate a hemorrhage in the urinary tract. Proteinuria or albuminuria means increased glomerular permeability. So it means that there's protein leaking into the filtrate, which could be an indicator of inflammation, something going on with those nephrons. The filtration units are becoming more permeable and too many of them are damaged, so you're losing protein. Bacteriuria, and pus, pyuria, could mean a urinary tract infection. Urinary cast indicate inflammation of the tubules. A cast is a microscopic mold of the kidney tubules. There's different types depending on what the problem is. You can have blood cell, white blood cell, red blood cell casts. You can have clear hyaline casts. And so that's a study unto itself, but these are protein precipitates that form a mold inside the smaller passageways in the urinary tract. Specific gravity. Specific gravity is comparing the density of urine to the density of water, and the number has no units because the units cancel out. So it's usually just a number, and the range is between 1.001 to 1.035, with normal urine falling in the range of around 1.010 to 1.020. Anything that's really high tends to be cloudy. The precipitates will settle out. Anything that's very low, it means that it's more water-like, very dilute urine, very hydrated. So that's specific gravity and actually what it refers to. So the kidneys are supposed to be able to concentrate the urine. So if it is very low, dilute urine could be related to renal failure, assuming that dehydration is normal. And very high could indicate that a person's not very well hydrated, or there's a serious infection. Blood test. Serum urea, which is measured in the test called a BUN, blood urea nitrogen, and creatinine test. The kidneys are responsible for excreting these two nitrogenous waste, and if you have an elevated urea, an elevated creatinine, then you may have a decreased glomerular filtration rate going through the kidneys. Remember that the kidneys have 1 million nephrons. These are your filtration units. So 2 kidneys, 2 million nephrons, and the glomerular filtration rate runs about 120 to 125 milliliters per minute, which equates to about 180 liters of fluid derived from plasma every day. I'm just trying to review some of the basic A&P. So if your glomerular filtration rate is down, then you may have a lot of proteins building up, and this could relate to serious problems. The second one is metabolic acidosis, which relates to low serum pH and also equates to a low bicarb level. Bicarb is balanced and regulated by the kidneys, and bicarb is a base. So if you have low bicarb, if you're losing too much, that's going to cause your pH to be decreased. So kidneys are not controlling the acid-base balance. There's a problem here, a disease state going on, or some problem where the nephrons aren't regulating acid-base balance. Anemia, decreased erythropoietin, or bone marrow depression can cause anemia. And remember that the kidneys are the major source of erythropoietin, which helps to increase red blood cell production. So any problem there with the kidneys and not being able to produce EPO could result in anemia. Electrolytes. Electrolyte concentration depends on regulated fluid balance, and the balance of these electrolytes is controlled by the kidneys. So very important tests can indicate what's going on there. Antibody levels. ASO, which is anti-streptolysin, and ASK, which is anti-streptokinase. These are used for the diagnosis of post-streptococcal glomerulonephritis. These are antibodies that are produced when that disease is present. Renin levels. Renin indicates the cause of hypertension because renin is produced as part of the pathway of producing angiotensin II, which increases aldosterone levels, which is going to increase sodium, which will retain fluid, increase fluid volume. And also angiotensin II is a strong vasoconstrictor, which will which will increase blood pressure. Other tests that can be done: culture and sensitivity test, clearance tests. Creatinine is one that's done quite often. Inulin is another test. Radiologic tests, intravenous pyelography, angiography, ultrasound, computed tomography, a CT scan, magnetic resonance imaging, MRI, and radionuclide imaging. These may be used to visualize structures and any abnormalities in the urinary system. Diuretic drugs, also called water pills, are used to remove excess sodium and water from the body. They are prescribed for many disorders other than renal disease. High blood pressure, edema, congestive heart failure, and pulmonary edema are some other things these are prescribed for. Sodium chloride reabsorption inhibitors. You have hydrochlorothiazide, hydrodiuryl, which is a mild diuretic, furosemide, Lasix, more potent, and potassium-sparing types, because these first two may cause the loss of potassium. And sometimes with the first two, dietary supplementation of potassium may be necessary, and that excessive loss of electrolytes may cause muscle weakness and cardiac arrhythmias, also dry mouth and increase of dental caries. Orthostatic hypotension, a drop in blood pressure occurring when a person rises to a standing position. These are all possible side effects of number one type of medications, sodium reabsorption inhibitors. Now, potassium-sparing types, aldactone causes increased potassium levels in the serum, so this is good because that helps to regulate that sodium-potassium balance. Remember, the sodium and potassium are on an exchange system, so many times if you upset the balance of one, you upset the balance of the other. So this one here tends to help with the potassium regulation. Dialysis, artificial kidney. Okay, dialysis is something that if a person really has a bad kidney disease and there's no other alternative and they lose too many filtration units, there are two forms. This can be used to sustain life after kidneys fail. So hemodialysis is provided in a hospital or a dialysis center, and the blood is processed through a filtering system to remove waste and retain vital components in blood plasma. This procedure is required about 3 times a week, and each session takes 3 to 4 hours. Peritoneal dialysis can be administered in a dialysis unit or at home. It's at night while the patient is sleeping, or continuously while patient is ambulatory. Continuous ambulatory peritoneal dialysis, that's CAPD. The peritoneal membrane serves as the semipermeable membrane, and the fluid is introduced into the peritoneal cavity by way of a catheter. The major complication risk is of peritonitis. So it's used, but hemodialysis is the one you see more often. And this is just showing you types of dialysis. It's showing you hemodialysis here, and showing you how the blood is pumped through a machine that exchanges fluid and is based on osmosis and concentration of solutes in the solution with whatever's in the blood. This is your peritoneal dialysis, using the peritoneal membrane as your semipermeable membrane, and it's just showing you here the difference in concentration of the various electrolytes and the principles of dialysis. Disorders of the urinary system. Urinary tract infections, extremely common. Cystitis and urethritis are infections of the lower urinary tract, and pyelonephritis is upper urinary tract infection. The common causative agent is E. coli, and this comes from the intestines. So it's a resident flora of the intestinal tract, and it's due to the anatomical differences more common in females, because females, wiping back to front, can transport these microbes from the anus and into the area of the urethra, and they can migrate into the urinary passageways and cause problems. Men tend not to have this problem due to their structural differences. Causes of infections. Incontinence is the first, incomplete emptying of the bladder. Bladder retention of urine. Any obstruction to urine flow, which tends to result in the growth of organisms. Pregnancy, scar tissue, renal calculi, and vesicoureteral reflux, which contribute to infection because the urine and any contaminants do not flow freely through and out of the system. Immunosuppression, impaired blood supply to the bladder, which happens with aging. Diabetes mellitus, vascular impairment, and glycosuria are the major problems there. And nosocomial infections from catheters and other instruments while in the hospital. Cystitis is another type of infection where the bladder wall and urethra are inflamed. They're red and swollen, maybe ulcerated, and because of the inflammation, you have a reduced bladder capacity. Signs and symptoms: lower back pain, dysuria. Systemic signs: fever, malaise, nausea, leukocytosis. Urine presents with being cloudy and very odorous. And when you do a urinalysis, you will see that there's over 100,000 microorganisms per milliliter in the urine. Pyuria and microscopic hematuria are also present. Pyelonephritis is an infection of the kidney, and this is where you have an an infection of the entire kidney. Can extend through the calyces and into the cortex region. Abscesses and necrosis can be seen in the medulla region, and recurrent or chronic infection can lead to scar tissue formation, and if it's severe and on both sides, bilateral, it can eventually cause chronic renal failure. Signs and symptoms similar to cystitis, except that the pain associated with renal disease is usually a dull aching pain in the lower back from inflammation that stretches the renal capsule. Systemic signs are more noticeable in pyelonephritis, and the presence of urinary cast, either leukocyte white blood cell cast or renal cell cast, are usually present. Treatment of UTIs, trimethoprim, Bactrim is an antibiotic, very easily treated usually with antibiotics. You should increase your fluid intake. Follow up antibiotic treatment with urinalysis to be sure that the infection has been totally eradicated. Chronic pyelonephritis can cause insidious damage to tissue and increase scar tissue damage that can result ultimately in chronic renal failure. Cranberry juice is indicated as a prophylactic measure. Tannin content reduces the ability of E. coli to adhere to the bladder mucosa. More disorders, inflammatory disorders, glomerulonephritis. There are many forms, but we're going to focus on acute post-streptococcal glomerulonephritis. That's a mouthful, APSGN. It's caused by group A, beta hemolytic strep, and it's usually a secondary infection. It originates as an upper respiratory infection or middle ear infection, strep throat, and generally affects children between the ages of 3 and 7 years of age, and especially boys. The pathophysiology: anti-streptococcal antibodies in response to strep infection from antibody-antigen complexes. This is a type 3 hypersensitivity reaction, and if you remember from A&P, that's where you have antibody-antigen complexes that deposit in tissues. These complexes lodge in the glomerular caps, and they activate complement. Complement, one of the processes that is caused by complement formation is inflammation. That increases capillary permeability, so you get more proteins and red blood cells in the filtrate. That's going to decrease glomerular filtration rate, and it reduces renin secretion. You get elevated blood pressure, edema, and ultimately kidney scarring. Signs and symptoms: back or flank pain, dark and cloudy urine due to increased protein that's leaked into it. Oliguria. Oliguria means you're not producing much urine, and that's from decreased glomerular filtration rate. You have facial and periorbital edema, and that's from decreased blood proteins and increased sodium and water retention. General signs of inflammation: malaise, fatigue, headache, anorexia, nausea, and also increased blood pressure and increased renin secretion to try to increase hydrostatic pressure and decrease glomerular filtration rate. This is the development and course of APSGN, and doesn't hurt really to look at this and go over this one more time. So you start out with your streptococcal infection, upper respiratory problem, antibodies form, and several weeks later you notice that these two enzymes are increased, and these antigens will produce antibody-antigen complexes that deposit in the glomerulus, which results in acute inflammation and damage, And the increased permeability of the capillaries causes hematuria and albuminuria because these substances leak out from the capillaries. The glomerulus starts to swell, cells proliferate, it causes congestion, decreased glomerular filtration rate. It's going to reduce the amount of urine that's produced and cause an elevated serum urea because you're not getting rid of the urea in the urine. And then you end up with stimulation of renin secretion, which elevates blood pressure, results in edema. And most people recover from this. A few will present with acute renal failure and recover, and if they don't, then that results in death. Some will go into chronic glomerulonephritis, which results in fibrosis, destruction of tissue, and ends up with chronic renal failure. So that's the development. So there are several different outcomes here, just depending on how early it's detected, what the treatment is, and the condition of the kidneys. Every person is a little bit different when it comes to these type of infections. Changes occurring in the nephron with APSGN. It shows you a normal glomerulus, and then it shows you a mild case of glomerulonephritis. So you see the swollen endothelial cells, the inner lining of that passageways, and you have a narrow capillary lumen. Glomerular filtration rate decreases because you have a constriction in that passageways. In passageway, immune complexes form, causing inflammation, and then that's going to cause red blood cells and proteins to leak into the filtrate, so that's your hematuria and proteinuria. And then severe glomerulonephritis, a lot more swelling, immune complexes are depositing, severe inflammation, very little blood flow here, and very little urine formation. So just showing you the difference between mild and chronic. Okay, so glomerulonephritis, a little bit more as far as diagnostic tests go. When you're looking at blood tests, you'll see an increased blood urea nitrogen. Creatinine levels will go up because of the decreased glomerular filtration rate, and you'll see an elevation in those antibodies, ASO and ASK. You'll see a decreased complement protein. Metabolic acidosis because of decreased bicarb and pH, because the kidneys are unable to regulate the balance of electrolytes here. And urinalysis, which you'll see there, is proteinemia, so a lot of protein, gross hematuria, and red blood cell CAS. So those are some of the things that you'll pick up. Treatment. Glucocorticoids, so these are anti-inflammatories to reduce the inflammation, restrict sodium and possibly protein and fluid intake until the problem passes. Sometimes antibiotics are a prophylactic measure. Acute renal failure develops in about 2% of all cases, and chronic glomerulonephritis persists in about 10%, which gradually destroys the kidneys. Inflammatory disorders, continuing on, Nephrotic Syndrome, or also called nephrosis. It's a secondary condition in adults, but it's a primary disease in young children. The pathophysiology develops as follows. It's not really well understood, but what you see is abnormality in the glomerular capillaries. So it causes increased permeability that allows large amounts of plasma proteins, especially albumin, to escape into the filtrate. This results in hypoalbuminemia, which develops and causes decreased plasma osmotic pressure, because albumin is important. It's an important colloid to keep fluid in the capillaries. So if you're losing albumin, you're going to lose fluid. So that causes a leak of fluid from the capillaries into the interstitial spaces, which results in edema. And then you have decreased blood pressure because you're losing fluid into the interstitial space, so that's hypovolemia. And then Decreased blood volume results in increase in aldosterone secretion, which causes more edema because aldosterone is going to attempt to resolve the problem by increasing the amount of sodium, but the blood vessels are permeable due to the albumin depletion, and so more edema forms. So it's kind of like a vicious cycle. And also, there's an increase in blood cholesterol and an increase in lipoprotein in the urine. This is not really understood, but it's thought to be the liver's response to heavy protein loss. Signs and symptoms: severe edema. Treatment: glucocorticoids, prednisone. Condition tends to recur and requires frequent monitoring and treatment. Urolithiasis. This is another term for calculi or kidney stones. These are common and frequently recur if the underlying cause is not treated. Pathophysiology: kidney stones tend to form where there are excessive amounts of relatively insoluble salts in the filtrate or when water intake is insufficient, causing a concentrated filtrate. 75% of calculi are composed of calcium salts. The rest are composed of uric acid, struvite, which is a magnesium ammonium phosphate complex, or oxalates depending on the predisposing factors. Alkalinity favors formation of calcium stones: phosphate, calcium oxalate, or calcium carbonate. Acidic urine favors uric acid crystals. Stones can obstruct the flow of urine, leading to the development of hydronephrosis from back pressure behind the stone. Signs and symptoms: stones in the kidney or bladder are frequently asymptomatic unless frequent UTIs lead to further problems. Obstruction of the ureter causes an attack of renal colic. And renal colic consists of intense spasms of pain in the flank area and radiate to the groin region until the stone passes or is removed. The contraction of the ureter causes the pain in attempt to force the stone out. May also cause nausea, vomiting, cool, moist skin, rapid pulse. X-rays can confirm the presence of the stone. The treatment: small stones eventually will pass. Larger stones can be fragmented by extracorporeal shock wave lithotripsy, ESWL, and laser lithotripsies. These are non-invasive and don't require surgery. And then adjustment of pH by ingestion of alkaline or acidic substances may prevent reoccurrence. Hydronephrosis, usually a secondary problem to calculi, but also tumors, scar tissue in the kidney, or ureter stenosis or kinking of the ureter, or untreated prostatic enlargement can cause the problem. So this picture here is showing you a dilated area that's filled with urine and showing you some calculi here, renal tissue that dies because blood flow is not getting there, and showing you a picture of the problem. Tumors: renal cell carcinoma. Adenocarcinoma of the kidney is a primary tumor arising from the tubule epithelium. The early stage is asymptomatic and metastasizes to the liver, lungs, bone, or central nervous system at the time of diagnosis. Commonly occurs after age 50 and more frequently in men and smokers. The initial sign is hematuria and a dull, aching flank pain, a palpable mass, anemia, and erythrocytosis. Treatment is kidney removal, and the 5-year survival rate is about 50%. Bladder cancer commonly arises from transitional epithelial lining of the bladder and develops as multiple tumors and tends to reoccur. Tumor can invade other tissues through bladder wall and metastasizes through the blood to pelvic, lymph nodes, liver, and bone. Early sign, hematuria. Bladder cancer has a high incidence in individuals working with chemicals, in lab and industry, treatment, resection of tumor, chemotherapy, radiation, but not really the best outcome. Some of the people that I've seen that have bladder cancer, many of them, the 5-year life expectancy, not that good. So I haven't seen too much success with treatment of bladder cancer unless it's caught very early. Nephrosclerosis involves vascular changes in the kidney, can occur with aging and thickening, hardening of the arterial walls, cause reduced blood supply of the kidney. This causes ischemia, so reduced blood flow, and that's going to cause atrophy of the tissues. Renin production increases blood pressure, and this can result in renal kidney failure or congestive heart failure. Treatment. Some of the drugs, antihypertensive agents, diuretics, angiotensin-converting enzyme inhibitors, beta blockers, which block renin release. All these meds can assist in maintaining renal blood flow and decrease blood pressure. And that's the main thing here, is to reduce the blood pressure to minimize the damage. Congenital disorders. Vesicoureteral reflux. So it's a defective valve in the bladder, so that as the bladder fills, the backflow into the ureters is not prevented, and so the urine goes back up into the ureters. Agenesis. One kidney fails to develop. It's asymptomatic and kidney function is normal because people can do very well with one kidney. I've had a member or two in my family that it wasn't found out until later in life that they only had one kidney. Hypoplasia is a failure to develop to normal size, so the kidney is just smaller, and it's often a unilateral defect. It only happens on one side. Sometimes it results from fibrosis in the kidney instead of a true developmental flaw. Ectopic kidney. The kidney and the ureter are out of position, either in lower abdominal or pelvic cavity. Kidney function is normal, but if there's any kinking in the ureter, that's where you may run into a problem with an obstruction. Horseshoe kidney is where the kidneys are fused together. So they fuse during development, and it's common. Usually kidney function is normal. It just looks a little different. Adult polycystic kidney. When you see this particular type of situation in the advanced stage, it presents with a lot of blisters on the surface of the kidney, and these blisters are filled with urine. So it's very unusual looking. It can cause a floating kidney because the kidney can actually move up out of position. But the most common form is an autosomal dominant gene on chromosome 16. First appears around age 40, and it results in chronic renal failure, and dialysis is required. The cysts can become quite large, and they destroy kidney tissue and can spread to other organs. Polycystic disease in children is transmitted as a recessive gene and shows up at birth. The child is either stillborn or dies within the first month. So depending on when you have this will determine the severity of the problem. There is a polycystic kidney, and you can see all these blisters, and these are filled with urine, and as time goes on, more and more tissue is destroyed, and you can see here very little healthy tissue and a lot of open space here. Polycystic kidney. Acute renal failure. The pathophysiology here is sudden kidney failure, either reduced blood flow to the kidney or inflammation and necrosis of the tubules causes obstruction and back pressure, which leads to reduced glomerular filtration rate and oliguria. And the causes of renal failure: glomerulonephritis, which causes decreased glomerular filtration rate; severe and prolonged circulatory shock or heart failure, and you wind up, because of the problem, tubule necrosis results. Nephrotoxins. These are drugs, chemicals, or toxins: carbon tetrachloride, sulfa drugs, penicillin, non-steroidal anti-inflammatory drugs, penicillin, acetaminophen, aspirin. All these things can result in kidney cell destruction, nephron destruction. Mechanical obstructions: calculi, blood clots, tumors. These block urine flow beyond the kidneys and cause acute renal failure. Treatment: dialysis may be used to normalize body fluids during the oliguric stage. Recovery is evidenced by increased urinary output, but it is a very slow recovery. Chronic renal failure. Pathophysiology of this problem is gradual, irreversible destruction of the kidneys over a long period of time. Can be caused by chronic kidney disease like bilateral pyelonephritis or congenital polycystic kidney disease, or systemic disorders like high blood pressure or diabetes. Early stages of chronic renal failure: decreased reserve, 60% nephron loss, decreased glomerular filtration rate, and increased serum creatinine. Middle stage: displays with renal insufficiency, 75% nephron loss, glomerular filtration rate down to 20% of normal. You see increases in urea and creatinine in the blood, and large amounts of dilute urine are produced. End stage: you see uremia. So you'll see uremia is the pathology where you see a lot of urea in the blood. People become very sick to their stomach. They can't eat. Causes respiratory problems. They may present with uremic frost, where you'll see like a white frost on the skin. This is the body's only way or last resort trying to get rid of some of that urea. And this is where you have greater than 90% of nephron loss. Remember that you have 2 million nephrons, so you can get by with quite a few being destroyed. But once you reach that critical threshold and you're down below 20% kidney function, things start to go very quickly and the signs show up very fast. So very low glomerular filtration rate. So you wind up with fluids, electrolytes, and waste being retained in the body, and all body systems are affected, and dialysis or kidney transplant is required to maintain life. So this is showing you a chart with the number of nephrons. So here you have 2 million. There you go going down to 0. What's going on in the kidneys over here? And over time, with diminished amounts of functioning nephrons, what's going on and what the condition is called. There's normal, you got your 2 million nephrons. So you go down here to about 75%. You see non-functional areas, but everything still is working right. Then you see fibrosis over time, so that's scar tissue. You're not going to get that back. So you're down to about 50%. Now you have extensive damage and getting down to probably a third of normal function, and fibrotic kidneys over time, they shrink. And this is where you have end-stage uremia. So as time goes on, you go from 100% decreasing renal reserve, asymptomatic renal insufficiency, and then end-stage failure. But you have to get down pretty low before you really see it. And that's why sometimes these types of things are insidious. People don't know they have them until it's really far advanced. And then at that point, sometimes you may get it back, but many times you don't. You just have to really stay on top of it. Chronic renal failure, signs and symptoms. So early signs: increased urinary output or polyuria. Also, anorexia, so you don't feel like eating, you're tired, exercise intolerance, increased waste and altered blood chemistry causes bone marrow depression, increased blood pressure, late signs, oliguria, so you're not producing very much urine now, dry, itchy, hyperpigmented skin, peripheral neuropathy, so abnormal sensations in lower limbs, impotence and decreased libido in men, menstrual irregularities in women, encephalopathy, congestive heart failure, arrhythmias, hypocalcemia, hyperphosphatemia with osteodystrophy, and this is where you have defective ossifications of the bone due to calcium and phosphate imbalances. Diagnostic tests for chronic renal failure. The key indicators: anemia, acidosis, and azotemia, which is a condition of elevated urea and other nitrogenous waste in the blood. It's the medical term, not to be confused with uremia, which is the pathology associated with the disease process that is caused by azotemia over a period of time, and seeing the sickness and the uremic frost and the difficulty breathing and all the other complications, the pathology associated with uremia, different from azotemia, which is just elevated urea and nitrogen-containing compounds. Okay, so metabolic acidosis becomes decompensated and serum pH drops below that low edge of 7.35. Remember, the normal range is 7.35 to 7.45. And then azotemia, elevated nitrogen-containing compounds in the blood. The anemia becomes severe. And then you see these other imbalances like hyponatremia, low sodium, hyperkalemia, high potassium, hypocalcemia, low calcium, and hyperphosphatemia, high phosphates. Treatment for chronic renal failure: drugs are available to stimulate erythropoiesis and to lower phosphate levels, and drugs may be required to treat high blood pressure, arrhythmias, heart failure, and other complications.